right, we are gonna get going right at the top here. Got people trickling in. Thank you for joining us today on this Wednesday afternoon or morning, wherever you may be. Hope that your day is going well. I'm Katie Green. I lead marketing for Current Health, part of Best Buy Health, and I'm excited to welcome you to today's webinar focused on operationalizing acute oncology care at home. We've seen a lot of great innovation and excitement in the oncology space recently with regard to moving care at home. So excited to bring together an awesome panel of experts today to talk about how their organizations have gone about creating at-home experiences specifically for CAR-T and BiTE therapy patients. We know every organization faces unique challenges, so getting to hear from multiple people about the experiences that they've created and the many change management pieces that go into moving care like this into the home is going to be great. In terms of housekeeping, please submit your questions to the question box. We are aiming to preserve a few minutes at the end of today's session to answer some of those questions live. So please send them, and we'll hopefully get to yours at the end of the session. With that, I'm going to turn it over to our Chief Medical Officer of Best Buy Health, Dr. Ben Saniello, who is going to moderate today's discussion. Ben, take it away.
Awesome. Thanks, Katie. Howdy, everyone. I'm excited to be here and looking really forward to this discussion with our amazing guests. As Katie talked about, we're going to talk about operationalizing acute oncology care at home. And I think if I emphasize anything to show that we're going to talk about something a little bit different is that acute aspect. We're not talking about outpatient therapy or how you operationalize your oncology clinics. This is a new way of approaching what would normally be hospital care. So services that a health system would traditionally offer in the acute setting. So BiTE and CAR-T as great examples can now via the Best Buy and Current Health technology, remote patient monitoring devices and platform be moved into the home. I think this is really meaningful from a access and scale perspective, but also maybe most importantly from a patient experience, which is not to say everyone loves to spend a lot of quality time in the hospital, but being able to get these therapies and this care from, again, our amazing guests at home, I think is really, really exciting. So rather than have me talk about it, we invited these three customers to come on and talk about their experiences with these services at home. And of course, they're all working in very different regions and doing different types of care from each other. So I think it's going to be fun to get the different perspectives. I'm actually going to have them all introduce themselves. And then we're going to plunge into the discussion. So Tanya, why don't you go first?
Thank you, Ben. My name is Tanya Cox, and I'm the AVP of Operations for the Sarah Cannon Transplant and Cellular Therapy Network. My clinical background is as a hematopoietic cell transplant and cellular therapy nurse for more than 30 years with HCA Healthcare. And Sarah Cannon is the oncology service line for HCA, and our transplant and cell therapy network is comprised of 10 programs across the US and UK, performing more than 1,600 stem cell transplants and cellular therapy procedures annually. Thank you.
Dan, why don't you go next?
Yeah, I'm Dan Davis. I'm an internal medicine physician, and I'm the specialty medical director for internal medicine for our Greater Charlotte market and Atrium. As relates to this work, I'm the medical director for our continuing health strategy across our Southeast region. Atrium Health is a large multi-state healthcare organization as part of Advocate Health, and the Southeast is North Carolina, South Carolina, Alabama, and Georgia. And in my role in continuing health, I have oversight of our hospital at home program, as well as our mobile integrated health program, which is our community paramedicine program. transition services, and a variety of other home-based care strategies. Our oncology division is coming together as a team between Wake Forest, which is one of our markets, our Charlotte-based, our Levine Cancer Institute, and then our oncology services in the Midwest through Legacy Advocate Aurora.
Awesome, thanks. And Shri?
Thank you, Ben. Hi, everyone. My name is Sridevi Rajiv. I'm a multiple myeloma and cellular therapy specialist at the Memorial Sloan Kettering Cancer Center in New York City. So my interest in digital health and healthcare delivery transformation started during my HemOnc fellowship, where I trained at Mount Sinai Hospital in New York City, wherein under the leadership of the myeloma service, including Dr. Jagannath, Dr. Parekh, and Dr. Rossi, we successfully implemented an investigator-initiated trial evaluating the use of RPM in patients receiving CAR-T to monitor for an adverse effect called cytokine release syndrome. So both the institutions, my training institution and my current institution, are big cancer centers in one of the largest cities in the US, serving a wide variety of populations. And both institutions I've been a part of have been actively looking at optimizing inpatient bed availability. And one of the ways of doing this has been partnering with RPM technology. So I'm very excited to be doing projects and completing my projects in my past institution and implementing in my current institution.
Awesome, thanks. So I think we should plunge in. And while I immediately talked about the kind of significance of us talking about acute oncology care, it occurs to me there's a general discussion within oncology that maybe it's been a little bit more reticent and slow to embrace new technology, digital health, et cetera. So maybe I'd love some kind of opening thoughts on why it's been a laggard in that regard. Tanya, why don't you start?
Thank you. I think that oncology, and in particular blood cancer treatment specifically, is complex and highly acute. As you mentioned earlier, it's very lab and diagnostic directed with a lot of infusional needs. And our care systems are very centralized to enhance the care team efficiency, not necessarily the patient experience. So I think that any type of work in this space really requires re-engineering, creating new alignment with community partners. And our team has been engaged in this space in our work with an outpatient CAR-T therapy model. And that's where we have engaged with Current Health.
Awesome. Dan, what are your thoughts?
Well, first, I'm not an oncologist, and so I can actually speak to it from the hospital at home perspective, right? So we have actually the largest hospital at home program in the country. We've served over 10,000 patients since our inception. We have an average daily census in the 50 to 55 range right now. So looking at it from what we have been able to develop and build from a acuity perspective from our hospital at home program, we've been able to approach our oncology colleagues who have been a little bit reluctant to accepted that this is a viable way of taking care of relatively sick patients at home, and have been able to show across the different the spectrum of the disease processes that we've been able to manage that this would be an appropriate way for us to help to manage the oncology patients. So I think really showing that experience and that knowledge that we have taking care of relatively sick patients that aren't oncology to then bring the oncology team into the fold to say, let's give this a shot for your patients. To Tanya's point, patients want to be at home as much as possible. So that's really kind of how we approach it, is let's take our experience and how can we apply that to the oncology model.
Dan, is there like a specific reason, or like how did you pitch it to the oncology folks? Again, it sounded like you had success outside of oncology, so that maybe made it easier as a viable pathway, but were there specific things that made them more interested?
I think, yes, capacity primarily. The capacity for inpatient beds for, oncology, just like the rest of our inpatient beds, is extremely tight. Our 11 hospitals in the greater Charlotte market are running in at 120% capacity right now. And so there was concern about delays of care for patients. And so it was sort of the perfect opportunity for us to go to them and say, we can help you create this capacity. You have the need, the patients aren't they may not get their treatments in the time that you would like to get them. So let's sit down together. And it was an incredibly collaborative process by which we had our hospital home team, the nurses, the paramedics, the physicians at the same table with the oncologists to say, what is the key? What do we have to build to make this safe for patients? I think it was that team-based approach. One, the experience with acutely ill patients. Two, the capacity needs. And three, that team-based approach to let's get everybody at the table and map this out in a way that's safe and effective for patients.
So to shift perspective, maybe go from Charlotte to New York, and obviously Sloan Kettering focuses primarily on cancer versus general hospital at home. So what were your experience with that?
Absolutely. So again, Sloan Kettering has been treating patients with cancer. It's one of the oldest and one of the largest cancer centers in the US. And, if you've been to New York and if you've seen Sloan Kettering, it's a huge hospital. However, you're catering to every single cancer diagnosis possible. And as both Tanya and Dan mentioned, capacity is always a problem. And, just to provide context to the listeners of why capacity more recently became an issue is with the approval of these adoptive T-cell therapies or NK cell therapies called bispecific antibodies, trispecifics, CAR-Ts, CAR-NKs. Now, the FDA guidance based on how the clinical trials were conducted is that these therapies should be ideally administered in an inpatient setting. With specifically for CAR-Ts, it requires a 10 to 14-day monitoring for anticipated adverse effects like cytokine release syndrome and neurotoxicity. So you can imagine, we are giving our patients CAR-T cells and bispecific therapies, which also needs a 1-week admission period. So these are patients who are admitted to the hospital, not really with an acute problem, but obviously with a progressive cancer. They receive the therapies and they occupy the patient bed anywhere from 7 to 14 to 21 days. So that kind of limits patients who are coming into our ERs with acute issues like, again, I'm citing my own disease here, multiple myeloma, people who have compression fractures and cord compression, and they need that hospital bed. Whereas I have 5 patients upstairs who are just in the monitoring period for these adverse effects. So it's the advent of these therapies that increased, especially in hematological malignancies, our use of inpatient beds. And that really led to a crunch in inpatient beds. And we were like, there has to be a way in which we can replicate as much as possible the care that we are giving inpatient to the outpatient setting. And I think that is where, remote patient monitoring or RPM has its leeway in oncology.
So sure, you actually mentioned one of the specific risks, and I think this is partially what's so interesting about CAR-T, which is while, again, they have their underlying cancer, and the risk associated with that this is actually a treatment that, while they can initially look well, carries a fair amount of risk associated with it. And I love how you mentioned in your intro that you actually started at Mount Sinai because, of course, I know that you did some research specific in this area. So Can you talk a little bit about that risk with CRS and what you found in your work on this subject?
Yeah, absolutely. Happy to. And, when I joined Mount Sinai for hematology oncology training, it was in the throes of COVID, pre-vaccine, and the hospital was, you can imagine New York City was completely inundated with COVID patients, and all hospital systems were looking for a way out to treat patients with COVID, yet keep the other sick patients also outside. So that's when Mount Sinai as a hospital was looking at partnering with RPM companies, et cetera. And I can't, from my understanding of the processes that happened as a trainee, it was actually, as Dan was mentioning, other non-oncology departments that led the way in bringing RPM to the institution. I believe it was absolutely hospital at home, internal medicine, cardiology, they led the way. And seeing their success at oncology, we were like, okay, there is a potential, but you're absolutely right. There was, and there always is a hesitation for us to embrace that because our patients are sicker. However, this is the background in which we designed our investigator-initiated trial in trying to understand whether we are able to monitor patients who are receiving CAR-T cell therapy reliably using remote patient monitoring. And we did this whole study in an inpatient setting because, again, there was a hesitation to directly take patients on the outpatient setting. So very briefly, what we did was we designed a trial in which patients who are getting admitted for CAR-T therapy with relapsed or refractory multiple myeloma, they in addition to being monitored inpatient, they also wore the wearable device, and we captured vital signs. And then we went on to assess how the device was able to note the vital sign changes in addition to standard of care. What we found was really interesting. We had almost 30 patients who were on this trial. And in summary, we found that the device was able to note the earliest changes that were associated with consistent CRS was as early as 2.5 to 3 hours before the actual time when a nurse called that the patient was having cytokine release syndrome. And this was consistent. There were no missed events. In fact, we had a few more events than what the nurse labeled as CRS. So we are kind of postulating that this could be subclinical events that may not have met the ASTCT definition for cytokine release syndrome, which again was picked up by the device. So the IIT that we did was opening up to us was the possibility that yes, it is feasible. And yes, we may have a lead time in detecting changes in vital signs associated with CRS if we use continuous monitoring versus discrete monitoring on the inpatient setting.
Well, I love that example because I think one of the kind of opening concerns about doing kind of acute patient care at home has always been a little bit the safety factor. And I think any kind of opportunity to show that you're reducing risk, and again, not to cast aspersions on our inpatient hospital colleagues, but there are a lot of acute risk to being in a hospital, even if it's for the most benign thing. So I think the ability to show that this is not just non-inferior from a safety perspective, but in fact, it may produce extra data that we wouldn't even get in the inpatient setting by monitoring somebody continuously versus intermittently. Now, I also know that we promised to talk about operationalizing this, but before we do, Tanya, I know that you have actually done research in your CAR-T program, which I think is one of the largest outpatient CAR-T programs that exists today. And of course, you have a lot of data. So if you want to add a little bit from your perspective on what you found.
Sure, thank you. I love the work that Dr. Rajiv and her team have done because we think there is value in being able to identify these patients that are headed on that trajectory, right, of a grade 1 CRS. And we think that earlier notification allows us to bring that patient into a higher level of care without the chaos of an emergent admission. It gives us that longer runway to let us better coordinate getting the patient into that higher level of care for evaluation. So I think that that says a lot about decreasing the stress on the patient and the caregiver to be able to have that more controlled approach.
Awesome. I love that you brought that up. Okay, again, we are talking about operationalizing this, so a little bit shifting here. Let's talk about how you decide who is eligible to do this, recognizing that probably not all patients can be candidates for care at home in general, let alone acute oncology. Tanya, why don't you start?
Sure. So we have patient eligibility criteria, both for CAR-T, that is disease-based criteria, and then for the outpatient setting in particular. And so the patients must meet the CAR-T disease-based criteria, and then they must also be at low risk for tumor lysis syndrome, no comorbidities that are predictive of higher risk complications, no active CNS disease. And then we also have caregiver criteria. So the patient has to have a 24/7 caregiver. They have to be an adult, cleared by our psychosocial team. They have to be with the patient for 30 days and attend all of the medical appointments. They have to be capable of monitoring the patient for CRS and neurotoxicity, manage the patient's medications, have a transportation plan. So there's quite a bit of requirement around the caregiver space as well.
Yeah, and Dan or Shri, do you want to come in with a little bit what you do here? Shri, I'll start with you.
Sure. I think all the points Tanya mentioned, we also follow, the patient themselves should have what we call a good performance status. And by performance status, we mean that, they are functionally capable of doing a lot of activities of daily living by themselves. For the caregiver, all the points outlined, plus we really hope that it is a consistent caregiver, because sometimes we've seen that caregivers switch, and it's a caregiver who knows the patient from before, like they know a baseline. And the baseline is important because these therapies, one of the toxicities with these therapies is neurotoxicity, which comes with confusion and delirium. So we often try to see if the caregiver knows the patient from before, so that they know if there's a change in baseline. The other unique aspect, again, I know, Ben, we have talked about it with other challenges unique to a metropolitan area like New York City. There's often an FDA guidance of the REMS program, which is the Risk Evaluation Mitigation Strategy program, for patients to be within a reasonable driving distance of the center that's administering. And usually that guidance is like 1 hour. We try to extend that a little bit. We hope to extend that a little bit to 1.5 to 2 hours, hopefully with the assistance of remote patient monitoring, because, as you can imagine, the travel time lost in commuting into the city, in parking in New York City, all these factor into the ultimate time from initial detection to when the patient can receive treatment. So our hope is that we can increase our radius of where patients can safely stay at home and receive it. And that is a consideration, and that is an eligibility criteria we're actively incorporating. But everything else, what Tanya said, is what we are adopting.
I'm smiling because, of course, having trained in New York, I'm well aware of kind of the traffic factor in the bridge and tunnel. However, I just spent time with Dan in Charlotte, and I think they need a traffic factor in their eligibility criteria as well.
Interesting.
Yeah, just for any of you visiting the Charlotte area, but budget extra time for travel. Dan, you probably have some insights unrelated to the traffic, but
Right, absolutely. So I will say that obviously the oncology team has their eligibility criteria that they work with. We likewise have the eligibility criteria for hospital at home. Patient has to have a certain functional status to be able to do their ADLs, and we're a little less prescriptive about the caregiver because of the way the hospital at home model is constructed. We are in their homes every day. We do the neurocognitive screening by our MIH or community paramedic team that's there every day, except for the day that they go to get their treatment, when they go get an infusion. The initial infusion day, actually, we do have a visit from MIH, but the rest of the days, the day they go get their infusion, we don't do that. Daily virtual visits with providers and so forth. So they still have to have support, but because of the way the hospital at home structure is driven, is that we really have to minimize the requirements and requests of caregivers. As like a CMS directive, really, that we can't overburden caregivers with what we require for a hospital at home. So we try to provide as much of that support as absolutely possible. So it's really a sort of that hybrid between where the oncology team feels that the patient's appropriate and how we fit them into the hospital at home model.
That makes sense. I mean, I guess you talked a little bit about the experience piece. Maybe that's a good segue here. Maybe let's start. I do actually want to talk about the caregiver experience, because I think we are shifting so much of the onus to them. I'm going to wave my hands being a technology person and talk about the benefit from remote patient monitoring and our platform and capturing all that. But at the end of the day, that caregiver in the home with the patient does have an increased responsibility. But let's jump back a second, talk a little bit about the patient experience. And of course, Dan, you're doing that not just for oncology patients, but across the hospital at home program. I'd love to hear how you've kind of optimized that experience for the patient.
Right. So obviously, almost all patients prefer to be at home. One of the eligibility criteria really go into is patient consenting, right? So there have been some patients who've been a little reluctant to sort of trust the system that we've got you, right? And so making sure that the patients have that they're educated up front about what it means to receive this monitoring and this treatment at home, so that they have complete understanding of what the process would be. particularly around escalations. Like, so if I have a problem, how do I get in touch with somebody? So that, I think, provides a tremendous amount of comfort for the patient to be able to understand that we can be there, or that they can have a higher level of care very quickly. Making sure they understand who the team members are, right? So what is the nurse doing? What is the paramedic going to be doing in my home? The person is going into the home. How is the physician interaction, the hospitalist physician, and how do they communicate and interact with the oncology team to make sure that the patient sees that as one cohesive unit and not two groups that don't know what each other is doing. And quite honestly, we've had some road bumps to the first couple of patients as you're feeling this out and developing these strategies to make sure that those lines of communication work. Make sure the patient's comfortable with the RPM technology, which has been the thing that's allowed us to do this, quite honestly, and that they feel the comfort with it, and that they feel that they've got that ability to utilize the technology. So, and there's some patients that, quite honestly, the technology is a big enough challenge that they just don't want. They would prefer not to pursue it that way. But most patients with appropriate communication and education have been able to find the comfort in that technology. Again, I think making sure that we realize that we're going into their space, right? So we really have shifted the dynamic that the patient is really the one that's in charge. There's a way it really should be for all of healthcare, right? But that we respect that we are entering their space and their home. That we bring the hospital to them, but that we don't turn their home into a hospital. That we minimize the number of people that are coming in and out of their house, and to make sure that we respect that space, but at the same time provide a safe space for that experience. So, and overall, our patient experience scores have been about 10 points higher for patients that are receiving this care at home versus receiving it in the hospital. Their own food, their pets are there, their friends can visit, their family's there. So all in all, I think it's really setting the stage, executing on what you've promised, and then making sure that patients had that ability to be able to communicate with us.
Awesome. Well, I think that's a great summary of the patient side, but I do want to discuss the caregiver piece, because I think that is a significant consideration here. Tanya, do you want to talk about how you kind of optimize the caregiver experience and think about that?
Sure. Patients love sleeping in their own bed and having some control over their environment. There's no question about that. But what we've realized is that in creating that model, we also create stress for the caregivers. And sometimes that goes under-recognized. We really ask, I think, a lot of caregivers in this model. But we've had some really positive responses from caregivers who were very anxious going into this therapy with their loved one. But they said once they recognized that there was a clinical individual on the other end of that wearable who was monitoring that patient 24/7, they said it really took a lot of the stress off of them, right? They need to be able to sleep and be able to have breaks. And I think that providing this adjunct for them has been huge in terms of their satisfaction and stress reduction.
Yeah, and you touched on this a little bit earlier about kind of how you, in your eligibility criteria, but then again, shifting to the caregiver experience, are there particular things that you all do based on accepting them into your program?
From a caregiver perspective, yeah, absolutely. They're involved in the education and the and the discussions about what to expect, just like the patients are. I think also, from a caregiver perspective, having a loved one, particularly a spouse or a child or a parent who's in the hospital for up to 3 weeks at a time, adds a tremendous burden. Again, the traffic in Charlotte, maybe not quite as bad as traffic in New York, but I can tell you a lot of these patients are coming from rural areas. You didn't have an opportunity to tour around, but you get 30 minutes outside of Charlotte, and you're in pretty rural North Carolina. And so there's a lot of burden to that caregiver to travel back and forth to the facility where these treatments are being done. And so the more that we actually free some of that burden by allowing them to be at home with and some people that work from home, they're able to care for the patients. And so they don't have to interrupt their career because they are going to be with the patient, whether they're in the hospital or whether they're at home. So I think looking at it from the perspective of, yeah, they've got somewhat more responsibilities, but at the same time, they're able to sleep in their bed at night, and they're able to not have to drive an hour, round trip to go to the hospital to visit their loved ones. So I think it's both perspectives.
Awesome. That makes sense. It occurs to me as we've gone into a little bit of the finer points of how to optimize patient experience, we may need to step back a second and talk about what it means to start one of these programs, like how you even initialize it. What are the things you have to kind of tackle first? Shri, you actually are the only person that's been involved in two of these, first at Mount Sinai and starting it at Sloan Kettering. So what are your thoughts on this? And I can imagine there is even some differences significantly between those two places.
Absolutely. So again, going back to my initial institution, operationalizing the use of RPM was already in the non-oncology setting. I think they had embraced it much earlier and more of like from a QI perspective. I think in oncology, we always were behind data, like how will this work? How feasible is this? So I think we were focused on obtaining some data first before implementing on the oncology side of things. So, and a lot of buy-in from our patients and their caregivers, and most importantly, from nurses and our advanced practice providers like nurse practitioners and our physician assistants were really important because they are the ones who, before RPM came in, they're the ones who are picking up the phone and answering all the calls and letting clinicians know, like, hey, the patient's calling, they're having fevers at home, etc. So having a buy-in from everyone involved was really important. And so the feasibility was really important at Sinai. And I've moved on from there since after my training, but they are actively going ahead with implementing it in the outpatient setting. But right now, since I'm involved at Sloan Kettering in implementing a similar program, I can also say that in addition to feasibility, a lot of other practical considerations are also important. Like, again, we have, in addition to the main hospital in New York City, there are many, many regional sites that we have where patients get chemotherapy, and each site, including the main hospital, has an emergency room. So we got the ER doctors at all our regional sites and the main site together, talked to them about this plan, saying that, hey, these patients will be coming in from home when we find that they are firing off an alarm or we find we are concerned for CRS, and sort of create a easier pathway than just coming as a regular ER admission and then waiting for a bed. So buy-in from our clinic team, which is APPs, nurses, nurse practitioners, PAs, buy-in from the emergency doctors in our institution so that we create this sort of protocol for them to be easily admitted. Those were some of the biggest buy-ins we needed. And once they are out of the way, then protocolizing each attempt was an easier task.
That makes sense. I appreciate that, again, getting to do it twice at two places and seeing the differences. Tanya, I know you've been in kind of knee deep in the HCA since the beginning with your program. Do you want to talk about kind of similarities and differences?
Sure. It looks, I think, very similar to what Dr. Rajiv talked about. We had a 4-month runway to develop the protocols with our teams and Current Health. And so we developed a steering committee that included CAR-T coordinators and nurses and outpatient clinic charge nurses and APPs, very similar to what she described. And then every other week, we met with the lead IECT physicians to review that protocol, get their buy-off, and then we were continuing on with the development. We also did early case review data to make sure that if there were any gaps that we were addressing those. And similar to what was just described, we also have an ED protocol called a cellular therapy alert protocol that is implemented across all of our EDs. The patients have a card that activates that protocol when they go into the ED, and there are time stamps for activities that need to happen so that that patient is able to get moved to the appropriate location with the appropriate care within a certain limited period of time.
It's interesting, actually, hearing both of you talk, it occurs to me something, we've talked a little bit about patient and caregiver and institution, but this idea of provider interaction and kind of buy-in to this. And it occurs to me for many oncologists, this care at home model would also be just as new it is for the patients and the caregivers. So maybe, and again, Tanya, since you had just touched on it and it triggered this in me, which is how do you get provider buy-in in this? I mean, has that been an obstacle? How have you managed through that?
Sure. So this space is rapidly evolving in terms of care protocols. We get together monthly with all of our physician leads, and we just had our call last month. And for 60 minutes, this is all we're talking about, right? Is new literature and what is evolving in terms of safe care in an outpatient setting for these patients. So the clinicians are wanting to run while we're trying to walk this RPM model forward. And so it does create some tension. It's really challenging to keep up with that. I would say our providers are very progressive and they want to keep pushing the boundaries, which we certainly appreciate as long as we're convinced that we can do that in a safe manner. I think one of the lessons we learned post-implementation was that although our lead physicians were very involved in helping to design the protocol and approve all of that work, we could have used more engagement with all of the physicians. We found that some of them, when they were on call, were not as well informed about what's in scope and out of scope for the clinical command center nurses. They didn't fully understand exactly what the RPM limits might be. And so that for us was a learning point, was engage not just your leaders, but all of your providers at an earlier state in the planning.
That totally makes sense. And certainly working with our clinical command center at Best Buy, I certainly know the discussions you're referring to. And of course, it's been a journey for both of us as we figured out the kind of best and safest way to do it. Dan, you probably have a slightly different take on this. I don't know if it was easier because you started with a big hospital at home program and then moved into a new space. Was that helpful?
Yeah, absolutely. I think having that experience in sort of monitoring patients at different acuity levels was very important. And we're very experienced at communicating with different provider groups on the inpatient side to gain their trust, right? So one of the challenges that most hospital home programs will run into as they try to scale is buy-in from other teams, right? Whether it's hospitalists, whether it's cardiologists, surgeons, and then in this case, oncologists. So I think we're sort of used to doing that. And as I mentioned earlier, one of the things is bringing the teams together, right? So actually sitting down with the people that are going to be doing the work of the oncology on the oncology side, and the people that are going to be monitoring the patients on the hospital at home side, and building the processes that they both agree upon. So, like Tanya mentioned, it was several months of putting together, building sort of what we felt like were airtight protocols to address every situation. Of course, then you implement them, you realize there's a couple holes we need to plug, and so being able to pivot quickly and address those. But I really think it was the experience of that going to different provider groups to go after patients, so to speak, on the hospital home side. We also manage our own vital sign information, so we don't use the Best Buy command center. Our nurses have just done that from the beginning at hospital at home. So they have a lot of experience with interpreting vital signs from the hospital at home perspective and what needs to be escalated, what may not need to be escalated. Now, obviously, very different patient population. The attention to detail has to be incredibly precise. And so we had to, again, educate that team to be maybe a little bit more attentive to some of these particular patients. So it's been a journey, and I think it's all about communication, collaboration between the people that are doing the different arms of the work.
So that totally makes sense to me. And I like, we all have kind of consistently emphasized that we're all in kind of learning in a journey. We're now doing this in many different places and capturing kind of a wide swath of patients. But I think we know the newness to this. So I think that then kind of bears the question is, how do you know that this is working? Like, what are the measurements of either just success or even starting with kind of process metrics to know that you're capturing the right information and doing the right standard of care? I know, Shri, since you are, this is no offense to any of us on the phone, but you're definitely the most academic out of all of us. So, and I know I've participated in some pretty consequential studies on this. So I'd love your thoughts.
Well, thank you for that undeserved pedestal, Ben. However, I think, in terms of scientific metrics of trying to understand how feasible this is, we were primarily, in our earlier study of CAR-T, we were primarily looking at a few things. First of all was time to CRS, between CRS being, for all the listeners, cytokine release syndrome. It's one of the adverse effects that you can get after you get immune therapies like CAR-Ts and bispecifics, which involves fever, low blood pressure, and low oxygen saturation. So we were looking at, can this RPM detect CRS either at the same time or earlier than standard of care, which is nursing recorded vital signs? So time to CRS was one of the biggest considerations. We were also really looking at whether there were any missed events during this period of monitoring. Did the wearable device, or based on how the patient was wearing, and while they were inpatient, by the way, we did allow them to remove the wearable device as they would at home, meaning, for charging, for while taking a shower. But during all these, were there any missed events? That was really important. And were there more events than that were recorded from a nursing standpoint? So these were three important metrics that we looked in our inpatient study. Now, for the outpatient bispecific study that we are implementing, we are also looking at what is the degree of, or what is the number of hospital readmissions, how many patients will end up in the ICU despite using, earlier detection technologies. What's the tocilizumab? It's a medication to mitigate the effects of CRS. Tocilizumab or steroid utilization, and obviously patient and caregiver preference and satisfaction questionnaire. So these are some of the primary and secondary endpoints to many of the studies that we're doing.
Awesome, thanks. I couldn't get off mute fast enough. Tanya, I'd love your thoughts on this, because again, I think what's so interesting is the size of your program, also that it's not just multi-site, it's multi-state. So you've probably been managing at that at a, I'm going to call it maybe a corporate or a system level, with that kind of variety of location must mean a little bit complexity of ensuring they're kind of tracking in the right direction, capturing the right information, doing the right things. So love your thoughts.
Yeah, so just like Dr. Rajiv and team, we have been looking at resource utilization and adherence metrics. For example, we looked at hospital days. So in our planned inpatient CAR-T model, we have about 16 days average length of stay. And in this outpatient model, we were able to reduce that to about 4 days. So that's about a 75% savings, right? And hospital days, which, as we talked about earlier, is critical when we're all short those precious beds. Looking at adherence, are patients wearing the device for long enough periods that we feel that is safely able to monitor them? And we found our adherence, after hours adherence, so that was when the clinic was closed, was close to 90%, which surprised us at how well patients, were agreeing to leave the wearable in place. We're also looking a lot at the types of alarms. We think there's an opportunity to significantly decrease the noise that we're getting around alarms. And so doing some work right now on a protocol for individualizing those alarms so that we reduce the burden both on the clinical command center as well as on our teams and our patients.
I love that. I think, one of our evolution in this space is kind of realizing the difference between in the hospital acute care and home acute care. And as was kind of mentioned earlier, the opportunity actually for more data with continuous alarms, and then of course a platform to kind of separate the signal for the noise, sounds really compelling. And then you launch into, well, because you can't physically see the patient, your tendency early on in the program is to ratchet up the alarms. But that may undermine the point of them being home, which is getting a good night's sleep versus being, are you wearing your wearable right now? Can I wake you up, etc. And I was just thinking about that in context of just educating patients about the difference. And we talked a little bit about patient experience and caregiver experience, but I'm curious, what have you put in place to ensure that they're ready for the experience, I guess is what I'm thinking, just from like an education and support perspective. I don't know, Dan, do you want to start on this one?
Yeah, we have a pretty solid protocol for hospital in general, but also for these specific patient types. So we have the education that occurs from the oncology side, and then after they've been the patient has been identified and felt to be clinically appropriate by the oncology team, then our nursing and team nurse, we have a nurse navigator on the hospital at home side that then contacts the patient, does all the education about the wearable and about how we're going to monitor your vital signs, how often people are going to visit, how often you're going to have provider visits. And then when the device is actually delivered, the RPM device is actually delivered by our community paramedics the first day of their first infusion. When they get home in the afternoon, the paramedic then goes through the process of turning the device on, showing them how to use it, putting it on, showing them how to alert the nursing staff if they need help. What's the fail safe? What's the backup if if they're not able to use the tablet to be able to contact the nursing team. So it's a multi-step process from each of those team members. So what's the oncology perspective, what they need to know, what's the nursing navigator team, and then what does the paramedic hands-on do? We're looking at different models. We're actually looking at perhaps utilizing Geek Squad to be able to go into the patient's home to help with some of the technology. There's different logistics around that, but we'd love to free paramedics up to do paramedic work and be able to leverage other teams to help with the technology. But it's all about communicating the different ways in which the patient's going to interface with the technology so that they feel comfortable with it and feel comfortable with the monitoring part of it.
Yeah, and I'm pretty sure you just blew some people's minds with the mention of Geek Squad, which of course, while this is in a Best Buy context, I think people are unaware that we actively use our healthcare trained Geek Squad subset to do what we call over the threshold delivery. And just for context, that is because, of course, to do hospital at home, you need to ensure that they are technology savvy, that they have the Wi-Fi running and all of these things, and figuring out how to do this at scale. In other words, not using highly trained healthcare paramedics, nurses who traditionally would have to be the troubleshooting the electronics in the home, and instead using a lower cost but trained individual like a Geek Squad member is one way of doing this. I think, again, because Shree's on the phone, I think about the additional aspects of using Geek Squad in New York and your willingness to accumulate parking tickets as they deliver care over the threshold. Something to keep in mind, the differences in geographic devices. Just maybe to close out the patient education piece, and I know we don't have a lot of time, Shree, I thought you may be able to add some of your thoughts on this.
Sure, absolutely. I think Dan did comprehensively cover a lot of, I think between all three of us at our institutions, we have a lot of commonality. One thing that we have learned in our experience is that you can't just spring this on patients the last minute. So we have started to bringing patients a little bit earlier and introduce, so at the end of a clinic visit, our team will introduce a technology, will introduce a team, and then the vast majority of them, I mean, I very rarely had patients say no to us. Everyone is excited to try it. So bringing in patients a little earlier, introducing them to the technology, them seeing, oh, this is the device that you just strap on. It's not like a big, heavy thing that you have to carry around. Caregivers looking at it, being comfortable. And more recently, there have been instruction manuals that are in non-English languages as well. So all that has really helped with the buy-in and education piece of things. So those were two extra learning points to add.
I love it. And I think maybe right before we shift to some of the questions, I know we've gotten a bunch, though I think all of you have really tried to capture some of those answers in the discussion, which is great. But before we shift there, I always think it's really important to talk specifically about what happens to patients here. So if you guys are willing, and of course don't violate any PHI, but any patient kind of specific stories with this, kind of testimonials or situations that you've heard that have really resonated with you. Tanya, since I've spent some time with you in this subject, I'm going to start with you because my memory is you have a good one.
Sure, thank you. Mine's actually from a caregiver that I alluded to earlier, who was extremely nervous going into this with her husband, who was the patient. And she came back into clinic just before they were discharged from the program and said, I just want you to know what a difference this made. It reduced my anxiety, reduced my stress, and really just made all the difference for her that she had a backup team that was also monitoring her spouse. So that was a very early testimonial for us that showed us the value.
I love it. Dan and Sri, do you guys have anything that you could bring up?
Yeah, we actually had a patient that declined to do the home-based monitoring. Said, nope, I don't feel safe with that. I want to be in the hospital. And then after their week in the hospital, they said, I'm going home. So because this was their first infusion, they didn't know what to expect. They just wanted to be in the hospital. And then after a week of being woken up all night long and eating hospital food and all the discomforts that come with being in the hospital, they said, no, I'm going home with this other. What was that other thing we could do? Was that at home? I'm going home. So that was one of our testimonials that they, and they had a very good experience at home as well.
I hope that isn't a negative testimonial about your hospital care, but I appreciate the context of, again, freeing them to a
tremendous
better...
amount of respect for our hospital, our brick and mortar colleagues. None of us want to be in the hospital. And sometimes if you've never been there, you don't really realize how bad it can be.
No, fair
in the best
enough.
of circumstances.
Fair enough.
I think
Yeah.
I can just add to the fact that, we had a patient who was on this and, in all their free time, they were exploring all the features and then kept asking us, oh, can I come on video and see? And they were asking for more technological capabilities than we actually had, because there were two such patients and they loved it. So to see that sort of embracing of technology was actually heartening, because we were thinking the opposite way. I think we are all a little pessimistic to begin with, thinking that will patients want this? Will it be too much for them? But it went the other way. In fact, they were like, why don't you build in this capability? Please give a feedback to the company you're working with. So that was refreshing to hear.
I love that. I think it's always a good sign when one of the feedback we get is that the patient doesn't want to, quote, turn in the devices or stop being monitored, meaning that while, again, I want to emphasize this is fairly invasive, they're wearing something on their chest or on their shoulder to provide their vital signs. There is a little bit of a natural kind of big brother aspect to it. So when we hear that it actually gave them peace of mind and they would actually, are they allowed to keep watching it? And would we continue monitoring? I'm like, that's, I think, a positive sign. Usually the answer, of course, is no. Unfortunately, we need to actually bring more patients into the program and you're done with your therapy, et cetera. But I'm always enriched by that, because there are very few patients that raise their hand and say, I would like to stay in the hospital longer. So I think that's a good sign. So I think we've gotten a bunch of questions that I have not been able to monitor because I can't multi-track. I think Katie is going to come back on and maybe grab a couple of those. I think we've gotten too many that we can probably cover in the next couple of minutes. Katie, why don't you pick some of the you think make the most sense?
Yeah, we've got a bunch. I think a number of them we can roll through answering very quickly. Tanya, this first one is for you. Do you hold a bed for emergent patients?
We do, but we don't hold a bed for every patient. So we hold a minimum of one bed. And then, once that bed is filled, then we make plans for the next open bed.
Makes sense. This next one is for Dan, from somebody joining us from the UK. Could you provide just a quick high-level overview about the hospital at home support that is available to patients?
So that's 3 minutes to discuss. That's very challenging, but
It's a tough to do quickly. Dan, go.
Very quickly. So we have daily or twice daily visits from community paramedics on usual hospital at home patients. Now, the oncology patients we visit once a day because they're technically outpatients, even though they're being cared for in our hospital home program. 2 visits per day by community paramedics, a virtual visit daily with a physician. And then 2 visits virtually per day with a nurse, and then 24/7 nursing coverage and 24/7 provider physician coverage, including night call too. So it's everything that you would expect in a hospital. We have the continuous monitoring, blood pressure, pulse ox, so forth, temperature. We also can draw labs. We're working on mobile imaging, so we don't have that quite yet. And then we can do both virtual and in-person physical therapy and occupational therapy as well. We have limited ability for consultation. Obviously, oncology patients have an oncologist that's a part of the team. We have cardiology consultation, GI, a few other specialties. We can do TPN. We have wound management. So basically, virtually anything that you can have in a hospital, we found a way to either do virtually or in person with the patients. Meal delivery, we provide meals for our patients as well.
Perfect. And Shri, this next one is for you. Is that trial data showing the earlier detection of CRS with a continuous wearable published and accessible for folks?
Sure. So this data was presented as an oral presentation just last December by me and my colleagues at the American Society of Hematology's annual meeting. We are actively in the process of writing up the full manuscript, and we hope to take it to publication over the next 2 months. But the abstract form of the data is available online if you search for it in the American Society of Hematology's program website. But we hope to get that data to you soon.
I'll actually go ahead and promise people I'll send you the link to that in the follow-up to today's session. And then this one is for everybody. Are you applying this model to bispecific antibody administration? Dan, start us off.
Yeah, so we are only doing bispecific antibodies right now. We have not done CAR T yet. That's the next step. The oncology team is working through the protocols, what needs to be done differently or not. So right now we've just done bispecific antibody therapy.
We are doing both, yes.
We are not using RPM for bispecifics yet. We are focused strictly on CAR T.
And this one, general as well. Can you speak to the number, we'll say roughly the number of patient escalations or the rate of patient escalation that you see with this model, defined as the number of patients whose care involved a transfer to a traditional inpatient setting for that escalated care? How often do we see that?
Right now, we're at about 20%. I think we're at about 20%, I think, in that range, have had to return for something. Now, some of those didn't stay. Some of them were able to come back home, but I think it was around 20%, which is higher than our usual hospital home escalation rate.
For our CAR T patients that's being performed in the outpatient setting, 70% of those patients got admitted at least under an observation status for CRS. And then another 15% got admitted for some other reason. I'm not sure if that answers the question. But.
I think so. Great. Let's see. We've got just a couple seconds left. I'm going to try to pick an easy one. I will say, if you submitted a question we were not able to get to, we will follow up with you to get that answered.
Yeah, Katie,
okay.
There's a lot of questions about reimbursement, and that probably deserves a separate webinar because,
webinar.
right, there is like There is absolutely, in the CMS kind of carrot home model, there is now a kind of waiver that provides reimbursement support for this, particularly with oncology. There are other kind of models, as well as there are RPM codes, et cetera. And there's obviously the kind of soft upside of additional bed capacity and program growth. But I'll try to figure out how we can talk about that more specifically, because it's really interesting and becoming easier and easier.
Yeah, very dynamic. I do want to be respectful of everybody's time today. Thank you so much for joining us. Panelists, thank you. Your insights were just really wonderful and fascinating. So really appreciate the time that you put into this. And with that, we'll send out the recording.
Thank you all. Appreciate you joining us.
Thank you
Bye-bye.
for having us.